So welcome everyone, I'm Dr. Jassam. I'm a neuroimmunologist and the MS specialist who recently joined Hoag to start the Neuro Immunology program. So we'll talk a little bit today about multiple sclerosis, and I'm not quite sure your level of knowledge about multiple sclerosis, but we'll take it from the very beginning. And then once you have questions, you can stop me and ask me at any point in time. These are some of my disclosures about the research I did and some of the stuff I've been doing over the years. So we're going to talk a little bit about what MS is, how do we treat it, if we can do more other than the drugs we use to treat MS, what is neuroimmunology by and large, it's a kind of a mouthful, and what lies ahead in the future of neuroimmunology, MS field, and how the immune system and the nervous system are interacting, will be interacting in the future. So this is kind of one of the, probably the only joke you're going to see in an MS clinic, is that MS is not MS, because there's a lot of literature and a lot of people who go and Google many symptoms and come into my clinic and they say, I think I have MS. And many doctors actually make that same mistake by assuming that symptoms of fatigue and confusion and tingling, they're all MS. Well, actually, you're going to see down the line that's not true. This is probably the first known case or historic case of MS. It's a nun from the Netherlands. Her name was St. Ludwina of Schiedam, who was skating one day, and she was ice skating. She fell because her left leg was weak, and they thought it was a miracle because she was a nun, because a few days later her leg started to get stronger, and of course people were praying for her. And the story goes that a few months later her vision starts to go weak, and they thought eventually she was cursed. And the stronger her faith was going, the stronger this test was getting on, and she dies at the age of 51, I think. After she suffers from progressive weakness, she became bedridden, and it is thought historically to be the very first case of MS that we know about in literature. Of course, at that time, it was faith rather than anything else. But we know how this progressed when Charcot, a very famous French doctor, physician, neurologist, who described many diseases, had one of his patients who developed similar symptoms, and at that time he tried the treatments that he knew worked. He tried wine, mercury, arsenic, none of which worked. And when this patient died, he took his brain to the lab and he found pieces of hardened tissue in the brain, and he called that sclerosé en plaques, which is, we call here multiple sclerosed plaques. Well, that's the term multiple sclerosis came from. So probably Charcot was the one who described it first. And that is kind of evolved with the concept of what actually causes these sclerosing plaques in the brain. And we know now this means demyelinating disease. What is demyelinating disease? Well, they take the tape, the insulation around the wires, if you wish, which are the neurons, the axons. When you take the myelin away, that's called a demyelinating disease. And it's usually acquired, means that we acquire it during our lives, but there is a genetic component to it. So it's not necessarily that we give it father to son and mother to daughter, mother to son, but in families, there is always history of some autoimmune diseases. So it does run in families, but it's not necessarily given by inheritance. Now, usually it affects younger populations, younger patients, but we are talking about the relapsing form of the disease, and we're going to talk about that a little bit. So the most common form of the disease, it affects female more than males, and usually in their 20s, although the earliest you might see MS is 2 years old, and the oldest I've seen is 72. So it can happen actually at any age, but usually it affects younger females. Now, usually the causality behind it have been blamed on multiple things, and just like everything else in medicine, the more we know about it, it becomes complicated, and we know it's multifactorial than just one cause. And we'll talk a little bit about the causes. In the last 2 decades, we knew a lot of new information about it. Now, it's very easy to overlook MS, meaning that the very beginning, patients tell you that it doesn't affect their life much, and they can brush under the carpet the first 2 or 3 attacks. They forget about it. Never happened. Okay, I had a little bit of tingling, some vision blurriness, big deal. But down the line, it catches up with one. So it's important to treat it early. And we know now that if you go to somebody who knows about MS, who can diagnose it early and intervene early, it makes a difference in the overall outcome. We didn't know that at the beginning, but now we know. Now this is a bit complicated, the slide, but just to tell you that there are different cells. I don't know if I have one of these cursors here, do I? Yeah. So these are all kind of different immune cells. So I've just put them in a diagram here, and they just attack that big cable, and those kind of pieces of insulation around the table, this is the myelin. So what happens is that the immune system attacks the myelin, destroys it, and leaves that copper wire, that nerve, bare. And when it's void of myelin, those same immune cells come and damage it, so it doesn't conduct electricity anymore. That's what gives us the symptoms. It becomes dysfunctional. That's the whole concept of all autoimmune diseases. When it comes to the brain, it can act in different ways, but when it comes to demyelinating disease, the immune cells attack the myelin, make the electricity go slowly in that cable. Now, MS is not one size fits all. It comes in different phases, different types. The most common type that we all know about is this guy here. We call it relapsing remitting multiple sclerosis. What does it mean? Well, it comes in attacks. It comes in bouts. The patient is hit by an attack, they get better, or sometimes they don't. The disability remains, but it improves slowly with time. But sometimes it's resolved completely, and that's the type we know. 85% of patients with MS have this. When the first attack of MS happens, before it became M, before there's multiple, we call it CIS, clinically isolated syndrome, which is basically the very first attack of MS. But now, because we do MRIs left and right to anyone with a headache, or MRIs are very available, we started to see people who are healthy, they have a bit of a headache or something else, and they have MRI that looks like MS. Now, what is that called? Well, we didn't know what is it in the first beginning, but now we call it RIS, radiologically isolated syndrome, which means that somebody who has the MRI that looks like MS, but they don't have MS yet. Now, how many of those people will have MS eventually? About 1/3 of them every year end up having MS or an attack that looks like MS. And there are certain ways to predict the risk about who might or who might not go ahead and have MS. Now, there's a form of MS that's called progressive MS. Now, what does that mean? That means that the disability, the worsening, happens not only because of the attack, but the patient can worsen without attacks. And those patients will come to clinic and say, you know, my walking, it's usually the walking. Always is the walking. And they tell you that my walking has been gradually worsening over the years. I don't remember a single day when I woke up with something like an attack or a stroke, what you tell me. But I can tell you, like over the last 3-4 years, my balance is not good. I'm using a cane more. That is more of a progressive type of MS. Now, if a patient starts with this, and within 15 years they start having this, we call this secondary progressive, because we started with the primary relapsing remitting and then became progressive, it becomes secondary. If from the get-go the patient doesn't remember ever having an attack, they just progress and get worse and worse, we call this primary progressive disease. About 10% to 15% of patients have this. It's a rarer form. This one affects older patients, and it affects males and females equally. Very different from that guy. Now, what's benign MS? It's kind of a mythical creature that has been debated for many years. It's a form of MS thought to affect about maybe 3 to 5% of population, very, very rare. And basically, the patient gets one attack after the other, but they never have disability. That means that the immune system has a very good way of healing the brain. So you can have attacks, but you never get disabled. Those ones are called the lucky ones. There are not that many of them. Now, facts about MS. About 1 million cases now recognized in the US. If you asked me 5 years ago, they were 400,000. So we either know more about it now, or we do MRIs more, or we're more aware. We hear about it more often. I don't know, but there's definitely more. We talked about the age of onset, the female to male ratio, the percentages being 85% to 15%. Now this is important because a lot of MS patients will come and tell you that I'm going to beat my MS by diet. I'm going to exercise, I'm going to live healthy, I'm going to beat it. Well, I tell you that from the good old days when we had no MS therapies, no MS medications, if you leave your MS untreated and you just do your best, vitamins, whatever you can do, about 50% of those people in 10 years' time will use some walking device, a cane, a walker, a wheelchair. So we know that untreated MS is not very forgiving. Now, why some people do better than others, we can talk about that all day, but as I said, some people have milder diseases, some people, all of a sudden the disease switches off and on because we don't know what starts MS in the first place. So it's very difficult to say that by modification of one lifestyle, let's say diet, because diet is the easiest thing we can modify, right? That we can cure MS. That doesn't happen. There's a lot of stories, and that's where the internet becomes a source for many of those magical stories. I healed my cancer by diet, or healed my MS by diet. Usually, scientifically at least, that hasn't been proven. There's definitely a big role for diet and gut microbiota and vitamins in MS care. But till this very day, I don't think we have good evidence that you can stop the disease or cure it by those only. This is the map of MS in the world. And interestingly, if you think this is the tropics, the disease gets higher the more north and the more south we go away from the tropics. So southern Australia, we don't have information about this bulk here. Russia and China, we don't have much information. But Northern America, Canada, Northern Europe, they all have very high incidence. Southern Australia, Southern Africa, we don't have much of Argentina in terms of diet. So it's basically the risk is not calculated. But you can see that in this part, it's way less than the northern and southern parts. Now, why is that? The debate has been, again, ongoing. Interestingly, if you travel from this area, which is the low risk, to this area, which is high risk, before the age of 12, your risk is as much as somebody who was born here. So there's definitely environmental factors, regardless of your genetics. Now, people have debated that this has to do with there were theories about it. People talked about sunlight, vitamin D. Some people said, well, these areas were very heavy immigration areas back in the day. This is where people came from all over the world, and they started to migrate. They lived together. They started to see each other, to meet each other, to live with each other. And the immune system for these humans didn't see the germs from the other sides of the world. They've never seen this. So all of a sudden, the immune system now is introduced to a new set of germs, of viruses, of parasites. And that's when the immune system starts getting things wrong. Because what is autoimmune disease? Autoimmune disease is basically the immune system attacking their own body. Now, they're not designed to do this, so it's a mistake. They are misinterpreting the myelin as a bug or as a parasite, so they attack it. Now, why is that? The theory is that some bugs have the same coat, the same covering as myelin, so they start to look like it. And there are other theories that pollution, certain infections that were inhabited in that area, we truly have evidence now that there are multifactorial environmental factors. Vitamin D stands very strongly as a factor that is not only a cause of MS, but a cause of worse MS. There are certain viruses. One virus is called EBV, or Epstein-Barr virus, the virus that causes infectious mono. Big smoking. Smoking doesn't only play in the causality of MS, but people who smoke and have MS will have worse MS. They get more disabled, they get more attacks. Certain genetic factors, people who have certain genes, there are about 400 genes identified with MS. there are certain criteria. If you start your MS with an attack affecting your walking or your motor or spinal cord or brainstem, you do worse. Males get it less, but do worse with MS. African American males now known to have probably the worst prognosis. So we spoke a little bit about all of these causes and the geographical location, the vitamin deficiencies, and each of those has a score, as in they have something called a hazard ratio. How much do they contribute? Like, for example, if somebody's a smoke and they eat a very lousy diet and they've had mono and they don't take vitamin D and it's deficient and they live over here, will they get MS? Not necessarily, because they need some genetic predisposition. They need that part, because there's a lot of people that I can tell you, persons who can have those shared features, but MS is not that prevalent. So there must be another switch, some genetic switch that can provide this. That's the interesting part, if we find a switch, but it's kind of the perfect storm, usually. Now, how do we diagnose MS? So somebody comes to my clinic, say, I have those symptoms, do I have MS? Or my doctor saw some spots on my MRI, do I have MS? Well, clinical suspicion, and that's what basically can be based on the patient themselves, their relatives, another doctor, or the provider, or another provider. But there's something called the McDonalds Criteria. Now, the oldest criteria for MS was something called the Poser Criteria. It came from the 1980s. But McDonald's Criteria has been alive since 2001, and they've just gotten updated. They get updated every few years. Now, what do they mean? The McDonald's Criteria talk about something called dissemination in time and space. That's the whole concept of how you diagnose MS. Now, what does that mean? Dissemination in time means you have to have events that happen at different time points. That's why it's called multiple. So the events have to be separated by at least 30 days. Now, what does dissemination in space mean? Dissemination in space means that it affects two different areas distant from each other in the nervous system, an eye and a leg and an arm, something different. They're distant. So when you have two or more of each, you fulfill the criteria for MS. So 2 points in time, 2 points of space, that's M multiple. And the S part comes from the MRI, how it looks like, the CSF analysis, that's fluid that runs around the brain. We check it for inflammation. There are other tests, we call them ancillary testing, certain vision tests and electricity tests. But basically, the MRI, the magnetic resonance imaging, has helped a lot in the diagnosis of MS. And that is because it has provided certain criteria to how an MS lesion looks like. And as we go and as a progression is made in time, we see advances in how we interpret these white spots, these abnormal hyperintense spots. This usually has been linked to not only MRIs of the brain, but also to MRI of the spine, because MS does affect the brain and the spinal cord. It's a disease of the central nervous system. So usually it's not only the brain, I'm showing you only the brain, but the 4 areas where we look for MS is called the periventricular area, which is basically around this kind of black structure there, or near the cortex, this kind of rugged type of structure called the cortex. So any white spot or lesion near the cortex called juxtacortical or cortical. And we look for it in the brain stem, which is the back of the head, or the cerebellum, which is the area where we control balance. And the 4th area is the spinal cord. So we have at least 2 of these areas involved to make that dissemination in space. Now, we spoke a bit about who might be doing worse with MS eventually. And we said that it's difficult to predict about MS because it's not one size fits all. But we know that if a patient starts with a motor attack or early bladder involvement, these patients do worse. If patient at the very beginning, you get somebody who have a lot of attacks at the very beginning, they get an attack every few months, that they're going to do worse. Or the duration for them to get better from the attack is longer They usually do worse. Why? Because that means that the disease is active, is very active, but also that means the healing is not very good. See, healing is an innate process and we don't control it. So if two humans get injured, the very same injury, they heal differently. And that's because of multiple factors: the immune system itself, the healing capacity, the health of that individual. So this is one of the innate processes. There are certain new biomarkers, and for years we needed biomarkers for MS because we don't have a way to predict. But recently there are more and more now awareness of certain blood tests that can tell you how somebody is doing with their MS. There's certain eye examination. There's a new examination called OCT, which check the thickness of the nerve of the eye. That can tell one how they're doing with their MS, if there's any progression. Of course, the MRI remains to be a very important player in how we're doing with our MS. Now, therapies in MS. There are, as I said, if we go back to the 1990s or maybe 1980s, there were no therapies approved for MS. Most of them were off-label, and that's why at that time there was not much to offer to those patients. But since that, it's now about more than just on 22 medications for MS that are approved by FDA. But by and large, when I talk to my patients about medications for MS, we talk about three main families or groups, if you wish. The first group are injectables, which means it's like insulin. They inject the medication under the skin or inside the muscle, and it comes either, usually now it's pre-filled in a pen. And those can come from different biological and mechanistical backgrounds, like a medication called glatiramer acetate. That's an innate form of medication that has no effects on the immune system, very mild. Interferons, another group of medications. And more recently, there is a new B-cell depleter called ofatumumab. They're pills, and the pills can come in different mechanisms, different toxicities, different side effects profile. We're not going to dive into this because it can get complicated, but just to tell you that they go from the type of administration to the strength to the side effect profile, and they range into a very wide range of mechanism of action. So it's definitely, MS therapies are becoming more and more complicated, and to choose is now becoming more of an art because you have to base it on multiple factors: the degree of the disease, the stage of the disease, the health of the patient, the age of the patient. Do they want to have children? Is their pregnancy anticipated? Side effects, other comorbidities. The list goes on and on and on. So it's becoming not very easy to just pick one from this list, and it needs a lot of assessment. Now, when the medications don't do much anymore, or the medication is already on, but the patient still having problems of the old injuries, we go into something we call symptom management. And symptom management, you basically have to notice all the other stuff that the MS has done for the patient. What about pain? What about constipation? What about numbness? What about falls? What about blurred vision? What about speech? What about all of these things? The medication don't take those away. The medication can't heal the damaged. The medication just prevents new progression, new lesions, new attacks. Well, what about the stuff that's already happened? Well, that takes, at the beginning, a lot of different therapies, like physical therapy, spasticity therapy. You send them to do cognitive rehabilitation for brain slowness, speech therapy, pain therapy. That's why usually in MS practice, the clinic is always multidisciplinary. You always need multiple specialists. You can't do it all in just one go. We usually bring the patient 2-3 times to talk about different problems. It's impossible to go over this with one specialist in one go. That's why MS care is usually a team. And if you're in a successful MS center, then usually it's a multidisciplinary approach. And that's why the concept of clinical assessment in a comprehensive MS center is important, because to be able to encompass all of these information, it's very burdensome. There are now certain apps, there are certain records, there are certain tests to tell you how you're doing, because even the patient forgets. A lot of the time the patient comes and sits in the clinic and says, how's your walking? Oh, it's kind of the same. But when you test them, it's actually better or even worse. And they can't notice it because sometimes the difference is minute. And the patient has stopped knowing. Or you send them and they think the MS is worse, but when you treat the spasticity, the gait gets better and they think the MS has improved. Now there's something called pseudo-exacerbation, false attacks. A lot of patients with MS know this. They say, we step out in the heat and we're worse. I take a hot shower and I'm worse. Now what is that called? That's called a Uthoff's phenomena. Uthoff's phenomena means when you heat a nerve that is bare of myelin, they don't conduct very well. And the nerve becomes more and more dysfunction. You cool it down, it becomes better functioning. It's a very old electrical rule, actually. It's an old rule of physics. But all patients with MS know that, and sometimes they learn it the hard way. Sometimes pushing themselves, if they walk, at the beginning they're fine. A few meters down the line, you see them dragging one leg, because that leg is now being exhausted. So there's fatigue. And fatigue does not always mean feeling tired, but actually there's something called muscle fatigue. The one limb will get more fatigued than the other, and it will become more dysfunctional. So that's why you need a good neurorehabilitation specialist. You need a good ophthalmologist, radiologist, even sometimes a hematologist, because some of these medications can interfere with the immune system. For the management of pain, you need a good psychiatrist or a pain management doctor to help you. There's a lot of counseling to go about the disease itself, what cognitive dysfunction. This is usually overlooked a lot in MS. Social work. MS is the #1 reason to lose employment in young adults, the #1 neurological disability in young adults. It's one of the major causes to lose employment. Not only because it's physically disabling, it's mentally disabling, it's psychologically disabling. One of the major complaints that some of my patients tell me is that people say that I look fine. Why do you say you're ill? Because MS doesn't show on the outside. Unfortunately, it doesn't. Patients with MS sometimes manage with their lives very well. They talk, you can't tell they have an illness. But once you look inside the MRI, you know, it's like, how do you walk with that thing? That's MS. It's insidious. It's insidious, and that's why it's difficult. That's why there's you got to have somebody to support the argument that this patient is actually disabled, although they might not look it. They don't have one limb, but they are disabled. Actually, this is kind of a concept that we recently came up with, is that the clinic in MS, one visit every few months, sometimes is not enough. It's always not enough, to be honest. There's a lot to talk about. And even the patient who come well prepared with a list that they've written down, you have to drift into one topic, and there's always a little bit of time to go through everything. So now there's more and more kind of centers where patients with MS will come and do a day-like program, just like what you do here. You know, it's but it's mostly for MS patients. They come, they do PT, they do meditation, they do OT, they do psych therapy, pain therapy. Specialists from different specialty will come and give us a quick talk. Pharmacist will sit down and talk to them. You name it. A dietitian who will go through different diets. That's new for MS. We're doing something similar here that we are hoping to start recently once things calm down a little bit from the pandemic. But it's definitely a place where MS patients will have support from people who do understand MS. Right. So patient support group, caregiver support group. Actually, caregivers, there's multiple articles about the burden of caregivers in MS, because those are the ones who do the transport, those are the ones who put the wheelchair, they pick it up, they have their own thing, they have to hire them. There's a lot of care that's required in MS, and those caregivers are usually not talked to during the appointment, apart from the healthcare for the patient. But that's the idea, is to provide some support network from people who understand MS a little bit more than just it's a chronic disability like a stroke, because it's very different. And you're right, the age group sometimes is very different. The requirements are quite different. There's lack of education in general about MS care because it's not a very common disease in terms, if you compare it to the other neurological diseases, it's not as common, and it's usually, it comes with kind of a lot of set beliefs about it, if you may. So the stages of MS that I just showed you, they're not very well known. Usually MS is thought of about either somebody who's in a wheelchair or somebody who looks well and just had optic neuritis, for example. The stages and the progression is not well known. So the idea is that we're trying to promote an educational program just to make people sure that all of this is MS, and there are different ways where people can be treated and managed outside just to give them a medication for MS, because there's a little bit more than that. But you're right, we don't have a specific place that I know of. Now, I wanted to talk briefly about what neuroimmunology is, because I said that at the beginning. Neuroimmunology is basically, MS is one of the diseases of neuroimmunology. Neuroimmunology is the science that talks about how the immune system affects the nervous system. And these are very complicated two systems. And so when they start to interact with each other, it becomes this mouthful group of diseases. They can resemble MS, and MS is the most common, but there are other cousins of MS that now we start to know them. In the past, they used to be called all MS. But now there are diseases that are rarer than MS, like a disease called NMO, a disease called MOG. They're all demyelinating disease, but they behave and act very differently from MS. But in the past, they used to be mistaken for MS. When it's not demyelinating, as in the myelin is not the main target, they call them neuroinflammatory diseases, where it's basically like rheumatological diseases of the joint, but in the brain. So there is neurolupus and neurorheumatoid and neurosarcoid. And this is basically, you see, an inflammation in the brain. Doesn't have to be with only myelin. The brain itself can get inflamed, the neurons, the blood vessels like vasculitis. This is, again, under neuroimmunology. And finally, there's a group of diseases that's caused by antibodies. So this is not inflammation. There's a specific antibody that comes and hits a specific target. And they call this branch autoimmune, like seizures. There's seizures that are caused by the immune system, certain diseases of the spinal cord, certain muscle disease like myasthenia gravis, for example. Guillain-Barré, a very famous nerve disease that everyone knows about, is mediated by an antibody. So all of these diseases kind of now are under the umbrella of something called neuroimmunology. It's a new science. People have now started to recognize it as a distinct group of diseases. In the past, those patients, because they are very rare diseases, didn't know where to go. But now there are specialists like myself who are getting trained just to treat these patients. So, important thoughts before we close this is the future consideration of MS. What's going to be new? We talked about what's available. The idea is now, can we fix the damaged tissue? And this has been an inspiration and a passion for many years, not only in MS, but in nerve injury by and large, like spinal cord injury, those accidental injuries. Can we regenerate? And unfortunately, in that name, a lot of mispractice has been done, like stem cell research. Stem cell is a big word that you hear about it everywhere. But till this very day, the usage of such cells or techniques in regenerating the nervous system, it's very primitive, and we don't have any good regimen how it works. Now, stem cell therapy itself, hemopoietic stem cell therapy, has been approved to treat aggressive cases of MS. But that's, again, this is not to regenerate the nervous system, it's to stop a very aggressive MS. So it's a little bit different from what we know. What we're talking about here is remyelination. How can we form the myelin again? Now, there's something very important that we brought in that very first slide, which was the picture of that cable, the nerve, and the myelin. You can take the myelin off, and then after that, the wire itself will be damaged. At a certain point in time, if you put the myelin back on, there's no benefit. The wire has already been damaged. And that's something that now, the reason why there's some remyelination techniques that don't work. In addition to the fact that the remyelination itself might be difficult structurally to put it exactly the same functional old way, But the damage, the axonal damage, the damage of the nerve itself happens very early. So sometimes even remyelination is a nice word, but it doesn't produce very good clinical effects. One of the passions for me that I actually like to talk about a lot is that can we predict MS? Can we know about the risk of MS in a society, in offsprings of patients with MS? Can we tell them what's the risk of them having MS in the future? This is going to be very important because we know now is that the earlier we detect MS, the earlier we treat it, the better outcome it is. So I think prediction studies are very, very important. Not only that, how about the patient who comes to us with the very first attack of MS, or even before the first attack, with those abnormal MRIs that we talked about? Can we tell them what they're going to look like in 30, 40 years? We don't have that tool yet. We can't say it for sure. We can say, okay, first attack was a bowel or a motor. Yes, your risk of disability is higher. If you don't get treated, I can tell you 50% chance you're going to use a cane in 10 years. We can say that. But can I give that patient an exact picture based on their blood test, of their images, how they're going to look like in about 10, 15 years? We don't have that yet. But there's multiple approaches now, multiple new blood tests, multiple MRI techniques, multiple genetic testing that can use something called precision medicine, which means that we identify patient factors to predict how they would do themselves, not somebody else who looked like them themselves, how they're going to do in 20, 30 years from the disease. That's, I think, is going to be the future of all of these diseases, because in that case, you can make an argument to say, okay, your disease is aggressive, given by 1, 2, 3, 4 factors that I have in front of me. So you'd rather use the strong medication to stop it in its boots now and don't let it run. And the other side, I can say, no, you know, your disease looks as if it has a benign mechanism or a benign outcome. You might want to start with the least effective but the safest medication for now, because your tests are not so bad. That's important, because the major fear for most of the MS patients is that what if my disease, my medication doesn't work, and if I fail it? What if I have another attack? Sometimes one attack doesn't sound like too much, but sometimes it's enough. I've seen one attacks who would render a patient blind in one eye. That's a big deal. I've had once musicians who lost their job because they couldn't play with that hand anymore. That hand became dysfunctional. It works, but it's not good enough to play with anymore. So they lose a job. So it's important. I think it's very important. Even one attack is important. So prediction, in my views, of the disease activity will be important. Thank you.
Thank you.
No worries.